this one here in this one, I should have detailed clinical evaluation with the two questions. Here are the two questions. If you examine any neurology patient or any neuro-ophthalmic patient, you should ask yourself where is the lesion and what is the lesion. These are extremely important questions. You can suspect where is the lesion and you can suspect what is the lesion, and depending on these data, you can choose. Either you can choose CT or MRI or another study or another radiologic study. Okay, and here the choice is based on what? Based on the differential diagnosis from the start, and after that, the nature of the suspected lesion. If you have vascular, you should ask for MRE together with the MRI. For example, this is for example. Okay, also the location of the lesion. If the lesion is suggestive of a view or a good view from the sagittal section, you should start with, or you should commence with MRI, because MRI is the only study that will view a direct sagittal view. So, or the sagittal section is exclusively found directly in the MRI, not in the CT. Also the patient characteristics, and here I want to focus on renal functions, because the contrast material either in CT or MRI in renal compromised patients or in renal insufficiency won't be good and will be contraindicated. Also the claustrophobia and the presence of pacemakers. These are limitations for the MRI. Claustrophobia because the patient is found in narrow and closed box, and here the pacemaker, if it is metallic, this won't be good, or this will be contraindicated for this patient. But right now we will have open MRI. This open MRI will overcome this limitation, and also we have non-metallic pacemakers, and this will be also good for patients to do MRI. But we should be sure of that before we commence the study. We should be sure that we have open MRI, not closed one, before we ask for MRI for the patient of claustrophobia, and also we should be sure that the pacemaker is not metallic. I want to ask you something. If you have some patient and this patient somehow has decreased vision or something, you suspect something, you ask for radiology, and the radiology didn't lead you to anything. I guess this is common, and this all of us have or had this problem before. Yeah. But this scientifically or scientific wise may be due to some errors, which may be prescriptive before I commence the study, or maybe interpretative after I, or descriptive after I commit the study. So if I have a prescriptive errors, what are the prescriptive errors? Here the patient failed to do the study, or he had inappropriate use of the study, or he omitted to be, or he refused to be injected with contrast material, and this may be important in demonstrating some tumors or some pathologies. Also, he refused, or the radiologist refused, to do some specialized sequences. So here we can be brief to summarize this one. Either the patient didn't do the study isn't done. Number one, the study isn't done at all, isn't done here. And number two, the study isn't done well, okay? Not well, isn't done well, or isn't done in a perfect way. So these are called prescriptive errors. So this is before the study, or I didn't do the study, either I didn't do, or I didn't do the study in the perfect way. Okay, the patient may do the study, but after that he may have interpretative errors, and these interpretatives are our errors. Okay, so here I may have misleading clinical information. If the patient is malingering and I believed in this patient, I believe that this patient doesn't see anything. This patient has no perception of light, and I suspected a neurological lesion before I do clinical examination well, and after that I can get a free MRI or a free CT or free study. This may be failure to detect the lesion due to misleading clinical information, or the reverse is true. Okay, so here the clinical information is extremely important because I can point to where is the lesion, or I can suspect where is the lesion and what the lesion, and before this or without this, the radiologist alone won't do anything for me. Okay, this is number one. Number two, rejection of clinical diagnosis because unexpected imaging abnormality is absent. You can write down here that not all of cases of multiple sclerosis will have white plaques. You know that cases of multiple sclerosis in CT around the ventricles like that, you may have white plaques here, here, and here. And here, this is not a rule. This is not a 100% rule for cases of multiple sclerosis. This the patient may have multiple sclerosis and has free MRI. So here, I rejected or I refused the clinical diagnosis, which is good, which is right, because I didn't see the white plaques, and this is another error. Okay, refusal of clinical diagnosis due to the absence of the imaging abnormality. Here, I can see striking imaging abnormality, but the assumption that this striking imaging abnormality is the only factor that is responsible for the lesion or the disease, this is not 100% true. This is not a condition. Okay, so I may have multifactorial diseases like headache, and if you see MRI with some lesion, you may with some striking lesion, you may attribute this to the headache, but the headache may be due to hypertension, which is another factor. So this is not that accurate example, but this I guess this is gut. Did you get this? The assumption that a striking imaging abnormality accounts for the clinical abnormality. I may have a clinical abnormality which is dependent from this striking imaging abnormality. Dr. Noura, are you with me?
Yeah.
Okay, and the example here, I may have multifactorial diseases. Okay, the factor that I can see in the neuroimaging is not the only factor that is responsible for this disease. Okay, here I have the reverse, failure to consider the lack of clinical specificity of an imaging abnormality. I may have imaging abnormality, but this imaging abnormality may cause a lot of diseases. Okay, a lot of variants, more than one clinical form of the lesion. If I don't know that this lesion is a condition that will be the cause of, sorry, if I didn't get that the imaging abnormality is not specific or not exclusive for this clinical form, for just this clinical form, this may be an error in thinking and error in diagnosis. So I misdiagnosis because of all of these. If we all revised all of these, you may find the clue that you were wrong. I was wrong because I didn't. I assumed that this striking abnormality is the cause. I assumed that the absence of white plaques means the absence of multiple sclerosis and so on. So these are all the interpretative errors. Okay, I guess if you apply this on your clinical, these errors will be somehow lower than usual. Do you agree with me in that?
Yeah.
Okay, so if you have CT or MRI, what will you choose for a case of neuro-ophthalmology? By the way, we prefer the MRI because it is better in soft tissues. So the MRI is the gold standard, but CT is also applicable for us. But what is the use of plain X-ray? What do you think of the plain X-ray? Is it useful or not? It is not that useful, but
no.
Yes, but it may be used for metallic foreign body due to or because of the contraindication here of the MRI. If I have a metallic foreign body, MRI is contraindicated, absolutely contraindicated. Okay, so let's start with the CT. This is, by the way, this is CT, and in CT I have just two views. Okay, this one, which is the anteroposterior view. I'll draw it in another color, in red, like that. Here, this one is the anteroposterior one, which is the anteroposterior view, and I have also this one, which is coronal section. Okay, here I have right and left. Okay, sorry, this is right and this is left. I'm looking from below. After that, I have also what I have also. This is anterior, and this is posterior. So this is called anteroposterior section. Okay, here I have the coronal section, which is here I have this part is superior and this part is inferior. This is right and this is left. Again, right and left, like this is right and this is left. Okay, so this is coronal section, and these are the two sections that are available or that are obtained from the CT. So let's go to the CT. Here we may demonstrate bone and calcifications well. Okay, so this is extremely important. If I have a lesion containing calcium or I have a bone defect, this will be demonstrated well with CT. So it is important to do CT, urgent CT, in cases of trauma or in cases of combative or yes, combative confused people. Combative, you know, I guess you know the meaning of this word, combative.
Combative, like fight. Yeah.
Yes, he's fighting.
Fight.
Combative
Yes.
means fighting. Yes, yeah. But here, what do you think of this? Combative means that he's fighting well and he's strong. But actually,
yeah,
actually here,
as in aggressive. Yes.
Yes, aggressive, but here this doesn't mean that he's aggressive at all. He's confused because he's beaten. Okay, yeah. But yes, and this is not an accurate or a meticulous word in this site. Yes. Okay, so this is important. But if we want to inject a contrast material, this may be important in demonstrating some tumors. I may check the GFR before. It must be below. Sorry, it must be greater than 60 milliliters per minute per 1.73 meter square. Okay. What do you think of this 1.73 meter square?
I don't know.
This is the area of. Okay, this is the average area of the human body. Okay, so here we can assume that all people will have this area. So it is written in internal medicine books. No, you don't have to memorize this, but you should memorize that the renal function is extremely important. If the patient is non-renal, before you inject him with a contrast material. Okay. What about this one, which is maximum intensity projection? This is to track something or to make a trachography for some nerve, like the third nerve or the fourth nerve or the sixth nerve or the second nerve, may have this trachography using the maximum intensity projection, which is formed of somehow helical or spiral cuts together with other cuts, and these 10 cuts are connected to each other to get a stereoscopic view of something. If I want to demonstrate the course of the second nerve or the third nerve, I may have, or I may do the MIP, maximum intensity projection. This is not important for us as ophthalmologists, but this is important for radiologists. Okay, I may have ionizing radiation with CT. You know this before. Ionizing radiation is some of the bad side effects of the CT. So per scan, I must have radiation which is below this number. This number is important, 150 milligray per scan. This is important. So I'm afraid of the danger of ionizing radiation. What are the advantages and disadvantages of CT? What do you think of this? CT is somehow rapid and cheap, good in bone, good in calcium, good in hyperacute intracranial hemorrhage. Okay?
Yeah.
What about the resolution? It is better than that of the MRI. So here in the CT, I have good resolution. I have good assessment for bone, good assessment for calcification, good assessment for hyperacute intracranial hemorrhage, and also it is cheap and fast. Okay, if you ask for CT, the patient will be back at the same day. Here in Egypt, I'm telling you, here in Egypt, if I require a CT for the patient will be back to me at the same time or at the same day. But if I require MRI, the patient won't come until tomorrow or until the day after tomorrow. Okay, so this is how can I remember? Okay, yes. Here the main disadvantage is that exposure to ionizing radiation, but also I have lack of direct sagittal imaging. This is extremely important. Okay. Also, I have poor resolution of the orbital apex. So if I have orbital apex syndrome or I have a lesion in the orbit that affect the orbital apex contents, I may refer the patient to do MRI instead of CT. Here is the contraindication if the contrast is required: renal insufficiency if the GFR is below 60 milliliter per minute. How about the MRI? What do you think of this? This is, by the way, this is the gold standard here for patients with a neuro-ophthalmic disease. The MRI is the gold standard. I have the power or the strength of the magnetic field in Tesla, which is from 1 to 3 Tesla in strength. Okay. Here, the image quality is dependent on 2 factors: the ratio of which is the signal to noise and the contrast to noise. If I have a lot of noise, I'll have poor. If I have here also a lot of noise, I'll have poor quality or poor resolution. But if I have this ratio and this ratio larger or more or bigger, I'll have better quality. I guess this is logic. Okay, if I have less noise, I'll have good quality. This is extremely logical. These are examples of normal MRI. Here, this is anteroposterior view. As you see, this is anterior and this is posterior. And to look at this, by the way, this vitreous may have vitreous hemorrhage or vitreous lesion, but this is not. Here in American Academy, he said that this is not meant by this photo. This photo is an example of a CT anteroposterior view. Here, this is the anteroposterior view, and here, this one is the anteroposterior view, but with another level. Okay, so if I have some person like that, this is a person like that, and this person, if we have a cut here and a cut here and a cut here and a cut here, these all of these cuts are anteroposterior cuts and will give me variable appearances. By the way, the appearances are beyond the scope of this course and beyond the scope of the ophthalmology, and they may require some lectures. Not that one lecture for them. They may require some lectures for this. For example, here I have this level like that, and I have below it this level. How did I know that this level is below this one? Because here I can see the pituitary, and here I can see the sphenoidal sinus. Okay, in its place. So this is how can I have a clue for the level of the anteroposterior view. Here also I have here something different, which is coronal section. Can you see this coronal section? Yes, this is the superior one, which is the brain, and below it I have the optic nerve like that. But this is with fat suppression. Here I suppressed fat in order to see the optic nerve well, but here this is without fat suppression. Okay, so these are all the CT, sorry, the MR sections. I have also the sagittal section, which is exclusive to the MRI scan. I can inject the patient with contrast also, which is gadolinium, and this is extremely important in altering the characteristic of the study, and they can cross the blood-brain barrier and be focused or be accumulated in the lesion, so they can demonstrate inflammatory and neoplastic lesions well. Also, this material may have renal and liver or renal and hepatic manifestations, so I may require renal and hepatic function, renal and liver function tests before I commence injecting the patient. What are the advantages versus disadvantages of MRI? Here the advantages: better in soft tissue, okay, so better in orbital apex, which was poor in cases of CT. Also, the intraparenchymal hemorrhage, no ionizing radiation. Also, I may get sagittal. We can add this here. I can get sagittal view as well. Here, the patient may have a disease due to the gadolinium toxin, sorry, the gadolinium dye injection, contrast dye injection. The contraindications is any metallic material within the patient. He may have cochlear implant, he may have ferromagnetic implant, he may have metallic clips. In cases of aneurysms, he may have renal insufficiency. He may have some metallic cardiac valves. So these are all contraindications. I may have technical, if the patient is too large for the bore, okay? The patient may be too obese to enter this narrow box. And also claustrophobia in cases of closed, not open MRI. MRA and MRV and CTA and CTV, they all share that they are less invasive than catheter angiography. By the way, catheter angiography is the gold standard, and they can be sensitive to any vascular abnormality. But here, they are extremely invasive, so I can depend on MRA or MRV if I suspect something, and I can do CTA and CTV. By the way, they have the advantages and disadvantages and contraindications like that of the MRI and CT. But here I highlighted this: the MRA or MRV may overestimate. Here the MRA may overestimate the carotid stenosis, and the CTA or CTV. This is important, by the way. If I have a bone like that, okay, you know that that bone will appear in white color in cases of what? In cases of CT. And here you will have a vessel, and this vessel will be also in white. Okay, so if I have aneurysm, this aneurysm will be missed. Okay, so if I have a closed proximity from the bone, I may have a misdiagnosis, or I may miss the diagnosis due to the bony artifact. Okay, also both either the MRA or the CTA, they may have limited resolution aneurysms which are less than 3 millimeters. These are the limitations, or not the limitations, the disadvantages of MRA and CTA. So here I have T1 and T2. Do you know the difference between them? T1 and T2 weighted MRI.
I know T2 for, I asked
Yes.
for T2 for the T2 flare for multiple sclerosis. I asked for T2.
Yes, yes, T2 with flare in cases of multiple sclerosis. You may ask the patient to do T2, and after that, because the CSF is bright and also or hyper intense, and also the white plaques beside it is also bright, so you may require fluid attenuation in cases of T2, and this is called, by the way, this is called proton density weighted or flare. Okay, so the T2 is sensitive to the areas of water content. If I have water content, I'll get hyper intense. But what do you think of the difference between them, T1 or T2? Which of them is more, let's say, which of them has higher resolution, T1 or T2?
T1.
T1, yes. So it is better in demonstrating the anatomy. Okay, that is because it has shorter time to repeat and shorter time to echo, and this will get more and more scans per second, and this will give me higher resolution than that of T2. But T2 will be sensitive to alteration in water content, so it is important in this will give me hyper intense signal in the vitreous, by the way. Let's look at this, and let's look at this, and let's look at this. What about this one, number 1? It is T1, okay, T1 weighted MR, okay. What about this one? It is T2. Can you see the vitreous here? Yes, the vitreous is hyper intense due to the high content of, yes, the high water content here of the vitreous. What about this one, number C?
This is T1.
No, there is a difference between here and here. Can you see the rims of these lesions? Yes, or this area? Can you see this rim? So this is fluid attenuated. So it is T2, but with flare, with fluid attenuated.
Okay.
Okay. Let's go for this. How about this one? And this one, and this one. By the way, this one is T1. Can you see the CSF here? The CSF here is dark, hypo-intense.
Yeah.
And here, this is proton density, or I can say that it is flare. Okay, so it is just like T2, but here with fluid attenuation. Yes,
yeah.
But here it is purely T2,
T2, yeah.
like that. And by the way, these lesions will be progressed to this level. These are the lesions after progression. So this is for the follow-up of some patient. By the way, to be sensitive to detect the lesion from the start, the flare is extremely gold and extremely good to detect the lesion from the start. It may be misdiagnosed. Here it is obvious and striking, but it may be misdiagnosed if it is a small, misdiagnosed when I use just T1. Okay, let's look at this. Can you see this one? And can you see this one?
Mm-hmm.
Okay, you have, this is sagittal view, by the way. You have here the eye, okay? And above the eye, you can see something, which is what? Which is mass, orbital mass, which extend, which caused bone erosion to extend to the frontal lobe. Okay, so this is extending epidermoid. By the way, this is not important, but here he says that if I have a proton density, here the proton density or the flare isn't good, because here the flare, the lesion is iso-intense to the frontal lobe or the other tissues, but here T2 will demonstrate well the lesion. Okay, I may have some fat suppression techniques, and this is extremely important. Here, if you suppose that A and B are the same person, here in A you may say it is normal. Here I can see no abnormality detected. Okay, but here if you have fat suppression, here is the fat in T1 weighted MR. Okay, if you do fat suppression, you can find this. Can you see this one? Here I have hyper intensity here and hyper intensity here, and this is called railway appearance, and this is a characteristic sign of optic nerve sheath meningioma. So you may misdiagnose this one if you don't do fat suppression. So if you are looking for orbital lesion, you must do fat suppression, and this may be asked. You can ask the radiologist to do fat suppression, or you can say or mention to the radiologist that you suspect an orbital lesion. This is extremely important. Okay, look at this one. This one is the same example. Here you may have fat suppression, and after that you can see this trim, which is hyper intense, and this is another example of optic nerve sheath meningioma. Look at this one and this one. Here, this is T2 weighted. This one here, T2 weighted, but here it is with flare. Can you see the proton density? I attenuated the fluid, and here I have demonstrated what I have demonstrated, the white plaques or the white lesions. What do you think of this one? Here you can say also here perpendicular lesions to the corpus callosum. So these are also white plaques suggestive of multiple sclerosis. Okay, here can you see the difference between the optic nerve in the right and the left eye? Here and here, can you see the difference of the optic nerve? Here in this arrow, it is more bright. Okay, this is suggestive of optic neuritis. So these are clues for diagnosing using these modalities or this MRI. But we can't say, or we can't look at all of the lesions at this section. This is just introduction for the neuro-ophthalmology. So we can study the disease first, and in each disease we can see the abnormality of it. Okay, I have also other modalities like Dewey, which is diffusion-weighted imaging. This is extremely sensitive to recent infarctions or strokes. If I have a cerebrovascular stroke and this is due to ischemic lesion or infarction, I can ask for this diffusion-weighted imaging because it is extremely sensitive in recent, within hours or even minutes. Here he mentioned that it is within minutes from the onset of cerebral ischemia. You may have apparent diffusion coefficient, which will differentiate between the artifact and the diffusion restriction or ischemia. Okay, these details are not that important, but here I want you to remember this one, which is Dewey, is a characteristic of recent alteration in perfusion, so they can diagnose recent infarction. The differences between edema and cytotoxicity, or cytotoxicity and vasogenic edemas, in cases or in edema in cases of cytotoxicity or vasogenic lesions, I may have differences between Dewey and ADC, and this is not important for us. Okay, so let's go to the final slides, which are for the catheter angiographies, MRA and MRV. I mentioned MRA and MRV before, but here let's talk about the catheter angiography. By the way, this is the gold standard one, which is extremely sensitive to all lesions, nearly all lesions of the vessels. A catheter is placed intraarterially, and iodinated radio-dense contrast dye is injected. I may have digital subtraction. This digital subtraction is important in decreasing the noise. Okay, and this noise may be a result of the overlying bony skull. Okay. Here, this is the important one. Just digital subtraction is extremely important. Here it is an example of posterior communicating artery aneurysm. By the way, this is not obvious for us. This is not obvious. But if you can see this, but because this view is lateral, so it won't be good. But if you have anteroposterior view like that, this is like the basilar course of any cranial nerve. And I guess that you are oriented with this. Here it is the pituitary or the Turkish saddle, the sphenoidal bone, the sella turcica. And here you can say that this is the internal carotid artery. If you can see any aneurysm in this area, this means that you have a posterior communicating artery aneurysm. So this is the same lesion, but this view we are oriented with. We are oriented with this this view more than this and more than this, of course. This is via MRE. Okay, I may have this one, which is MRS, magnetic resonance spectroscopy. This is important in detecting metabolic dysfunctions. You may have also functional MRI. What about functional MRI? By the way, this came out in an old exam or a previous exam, which is a patient with cluster headache. The patient with cluster headache may show a hyperactivity in functional MRI in the hypothalamus, because it is a sympathetic disease. Yes.
Where is it?
Okay. This is not mentioned here, but this came out here. If you, by the way, if you know I answered this question well. By the way, I answered it correctly. By the way, I didn't have the clue, or I didn't have this information typically, but I knew that the functional MRI seemed that like that the blood flow in the brain.
Can you repeat that again?
Okay, so if you have the function, what is the functional MRI? You can have an idea of the blood flow. So Dr. Noura, you can say me, and after that I'll say that the blood flow is good to the occipital lobe in order to see me well. Something like that. If you are hungry, the blood flow will be good or more to the hypothalamus in order to recognize it, or in order to feel hungry, and so on. So it is the patient is oriented, and the patient is performing specific activities, and after that, the blood flow, we may get a map of the blood flow in response to these activities. So the question was, what the question which came out in a previous advanced exam was that the patient had a cluster headache. And by the way, a cluster headache wasn't written. It was written that the patient have a headache which is intractable and is accompanied by lacrimation and tearing and so on. And this patient is which has a cluster headache. The diagnosis was cluster headache. This patient may have what? And the right answer was that the functional MRI will show hyperactivity in the hypothalamus. So this one was good. So the functional MRI may be done to detect hyperactivity in some areas, and in cases of cluster headache, you may see hyperactivity in the hypothalamus. You can have the PET scan, and this is also for metabolic disorders, and the SPECT, but this is this has poor resolution. This is not important, but we can depend on them if we just have normal MRI and we don't have any clue. So we can ask for the regular investigations, which are done regularly or requested regularly, and after that, if we don't have anything, we can depend on these irregular or these uncommon or not famous or not popular investigations, which are not present in all centers of radiology. So here, let's go to the ultrasonography. We may have ultrasonography on the eye, which is ocular ultrasonography, or ultrasonography, which is Doppler, to detect any abnormality in the blood vessels like carotid cavernous fistula. And here the ocular ultrasonography or the B-scan ultrasonography is important in detecting optic nerve head edema and differentiating it from the optic nerve head drusen, which may be calcified or white. In specific diseases, what to order, this will be repeated because here this is the curriculum of neuro-ophthalmology. So in each lesson or in each topic, I can remind you what to order or what are the investigations required. So in cases, for example, in cases of optic nerve drusen, you can require ultrasound. In cases of optic neuritis, you can require MRI. And also in cases of trauma, you can require CT. Okay, so these will be repeated in each lesson or in each topic or in each disease. So let's go to this question. On T2 weighted MRI, which would appear hyper intense. This is easy one, and this is question number 1 in Kenneth Wright book.
On the T2,
what do you think of this?
Would appear hyper intense, vitreous.
Yes, this is the vitreous, and this is easy one and obvious one. By the way, the depth of American Academy is good. You will notice this. The depth is good. You will see that the questions is below the level of American Academy, and this is extremely good for the exam. Here, this question is from Kenneth Wright, but this question is I'll answer this after we study all the diseases, because here this is dependent on specific details in the diseases like absent septum pellucidum or Demorcier syndrome or optic nerve sheath meningioma or neurofibromatosis, and this will be mentioned in this section after that. So I'll postpone these MCQs until we finish the whole neuro-ophthalmology section, and then we will be back to these questions again. And again, they are repeated from Kenneth Wright or review examination or review question, sorry, of ophthalmology 3rd edition. By the way, there are no radiology questions or neuroimaging questions in iDocs or ophtho questions. So this one is free or a vacation from the MCQs. So this is the end of this session. Do you have any questions, Dr. Moore?
No.